Assalamu alaikum. I welcome you all to our presentation on how to approach a patient with tinnitus. My name is Dr. Ali Shayan. I'm a resident in ENT SZHL Hospital, Lahore. ये नहीं चल रहा. I'll start my presentation with the brief description of what is tinnitus. The word tinnitus is derived from the Latin word tinere, meaning to ring or ringing. Tinnitus is usually defined as an unwanted auditory perception of internal origin. It is common and affecting up to 10% of the general population, with the most prevalence in 40 and 70 years of age. Etiologically, if we see that tinnitus occurs in most persons with normal hearing who are exposed to silence. It is also known as sound of silence. It is thought to be multifactorial in nature and can result from dysregulated neural activity along the auditory pathway as well as outside the auditory system. For example, in patients with somatosensory tinnitus, movement of head, neck, or limbs may cause tinnitus. The belief that tinnitus is entirely a psychosomatic disease, it is outmoded now. The most important causes of tinnitus can be understood by dividing it into two types, a subjective tinnitus and objective. Subjective is the one in which only the patient hears the sound, and in objective, the examiner can also hear the sound of tinnitus. The common causes you can see here are autologic causes include Meniere's disease, vestibular schwannoma, toxicological medications, many somatic causes, even as simple as wax infection can cause tinnitus. Many neurological diseases can also present with it. Infections of ear and different metabolic diseases may also play a role. The patulous eustachian tube, vascular diseases such as arterial bruit or venous hum can be heard if there are arteriovenous malformations. Neurologically, we can also appreciate palatal myoclonus or idiopathic stapedial or tensor tympani muscle spasm. These all are various causes of this disease. However, the more important thing is that we should focus on are the important associations. The condition most often associated with tinnitus is sensory neural hearing loss, and it is caused by presbycusis or occupational noise exposure. If there is conductive hearing loss along with tinnitus, then it can be due to wax impaction, middle ear effusion, or otosclerosis. The evidence that says that hyperlipidemia, diabetes, or vitamin B12 can cause tinnitus is very little and not conclusive. Associated medications, more than 130 medications have been reported to cause tinnitus. To decrease the risk of iatrogenic tinnitus, patients should avoid using more than one potentially ototoxic agent concurrently and should limit the dose and duration of such ototoxic medications. These medications include aspirin, NSAIDs, quinine, chloroquine, aminoglycosides, and about aminoglycosides. Tinnitus is usually an initial sign of ototoxicity, and aminoglycoside can cause permanent tinnitus alongside hearing loss. Macrolides, vancomycin, almost all types of antibiotics, loop diuretics, antihypertensive, antiarrhythmics, local anesthetics, topical otic preparations can also cause tinnitus. So a wide variety of medications can cause it. Now, as we have seen that there are too many causes of tinnitus and too many association with medication. So how can we diagnose it? How can we work our way around it? The main pillar of diagnosing tinnitus is history and physical examination. These are the primary diagnostic tools that we have. In the history, hearing loss and vertigo are the two most important associated symptoms that we need to investigate. The key elements of the physical examination include the head, eyes, ear, nose, throat, and neurologic system symptoms. Let's see the patient history findings for evaluating tinnitus. Associated events such as hearing change, previous noise exposure, acoustic trauma, otitis media, head and neck trauma. These are the questions that we should ask when a patient comes with tinnitus. The associated symptoms, these are headache, hearing loss, noise, intolerance or pain, temporomandibular joint pain, neck pain, or vertigo. These are the main associated symptoms. When a patient comes to you, you can begin, you cannot go into the history of tinnitus, and instead you can ask about the associated events and the associated symptoms. And then you can go towards the description of tinnitus. Is it fluctuating? What is the pitch? What is the quality and loudness? Is there a family history of such disease? What is its location? Is it unilateral or bilateral? What is the onset? It is gradual or abrupt? And what is the timing of tinnitus? Is it continuously happening or is it intermittent? And the last but not the least is the impact of tinnitus. This is by far the most important point that you need to ask the patient, because the impact of tinnitus will guide us towards our management of disease. Many times we are unable to find a cause for tinnitus, so our management is guided by the impact of tinnitus in patient's life. Tinnitus can be pulse style, in which you can the patient feels that the tinnitus resembles as that of a heartbeat. It can be pulse synchronous, in which it is similar to the heartbeat, and pulse asynchronous, in which it does not by ring with the heartbeat. In case of pulse asynchronous, usually mechanical causes are to blame. For example, middle ear muscle myoclonus, palatal muscle contractions, eustachian tube contractions. And in case of pulse synchronous, there can be a vascular pathology. That can be idiopathic intracranial hypertension, systemic hypertension, arterial or venous bruise or hums, AV malformations or vascular tumors. This is an example of palatal myoclonus. There is a clicking sound. I'm afraid we cannot play it here. This is another video. And this shows that how to palpate for aortic bruit. In this, he just places his phone alongside the posterior part of the ear, and we can hear an humming sound. And this is another video in which they show that there is intermittent clicking sound coming from the middle ear. And if you look closely, you can see a small contraction of a muscle that is happening inside the middle ear. The repeated contraction is producing a clicking sound, which is observable by the examiner as well. So what will be the physical examination for evaluating tinnitus? As it is an ear disease, we will start with the ear. A simple wax infection can cause this disease. There can be a fusion or a retrotympanic lesion. Then we will go towards the nearby structures. We will evaluate eye. We will check eye for papilledema, because raised intracranial pressure can cause tinnitus. Then we will check the musculoskeletal system, that the perception of tinnitus changes from the movement of mouth, neck, or different parts of the body. Then we will do the neurological examination, mainly the cranial nerve testing and the equilibrium, the finger nose test. But at the last, we can do the vascular testing to hear for bruise and murmurs over the ear canal, preauricular area, orbit, neck, chest. We can also put pressure in the neck to check that tinnitus changes with light pressure or not. As I have told you, the mainstay for diagnosing tinnitus is history and examination. However, we do have some tests, the ancillary and specialized tests for evaluating tinnitus. These are the ABR, the contrast enhanced MRI, simple plain MRI, pure tone audiometry, speech discrimination, and vestibular testing. Here I will say that pure tone audiometry is a very good test as it can rule out vestibular schwannoma. It can also diagnose Meniere's disease. So it is a baseline test that we are used to do. Next, we can do MRI. MRI, simple T2 weighted MRI is equally effective as contrast enhanced MRI for diagnosing vestibular schwannoma. And ABR can also strengthen as it is a simple investigation that if available can diagnose a lot of diseases including vestibular schwannoma as well. Speech discrimination is not routinely used and vestibular testing is rarely available to perform. Additional investigations that many people carry out are thyroid function test, full blood count, lipid levels, blood glucose, HbA1c. But as the studies have shown us, there is weak correlation between these diseases and tinnitus. Now the algorithm for evaluation. Let's say a patient presents with tinnitus. How will you evaluate him? I'd say we start with the question of hearing loss and vertigo, which are the two most important questions. If the patient has hearing loss, then evaluate for Meniere's disease with audiometry. Go for MRI if it is unilateral and the audiometry shows a sensorineural hearing loss. However, if there is no hearing loss or vertigo, then ask if the tinnitus is pulsatile or not. If it is pulsatile, suspect an arterial or venous origin, perform relevant examination, go for carotid Doppler ultrasound of the neck, or go for an MRI. However, if it is not pulsatile in nature, then you should concentrate on your examination findings. If on your examination finding you find a retrotympanic mass, acholestotoma, or a focal neurological finding, then go for audiometry and MRI to find the lesion. If the examination also turns out to be normal, then ask if it is a unilateral or bilateral. If it is unilateral, one may still go for an MRI to rule out vestibular schwannoma. However, if it is bilateral, then you should only do audiometry. Audiometry is the end result of all our investigations for evaluating tinnitus nowadays. What will the audiometry test show? If the audiometry test shows unilateral or asymmetrical sensorineural hearing loss, then go for MRI and again rule out vestibular schwannoma. If the audiometry test is normal, then you can, as here it is written, refer to otolaryngologist, but we are ENT specialists ourselves. So we will continue with the management of the tinnitus and not go for the investigation after this. Over time, there has been many confusions around tinnitus as what tests to order, how to investigate, how to treat this disease. And there are many ways that are being practiced and they have low scientific evidence for them. These are some key recommendations for practice, keeping in mind that these are C category. That means there is consensus and disease-oriented evidence, but evidence is not of significant quality to confirm these things. According to these clinical recommendations, patient with chronic tinnitus should undergo PTA. Patient with unilateral tinnitus or asymmetrical sensorineural hearing loss should undergo neuroimaging such as MRI. Non-contrast enhanced T2 or and T2 weighted MRI may be equal to the contrast enhanced. Patient with pulsatile tinnitus should be evaluated with neurovascular imaging. The choice of imaging technique depends on whether arterial or venous tinnitus is suspected. There are many red flags in tinnitus. I apologize for the shrinking of this slide. These are urgent referrals for the tinnitus. Tinnitus is a disease in which you might need to urgently do something about the patient. If you see here, if you see the tinnitus with suicidal ideation requires urgent referral. These are in accordance with NICE guidelines. And then tinnitus with focal neurological defect, such as facial paralysis or a suspected stroke, again requires an immediate referral. Tinnitus following a head injury also requires an immediate referral, and the sudden onset of pulsatile tinnitus or tinnitus with sudden onset of hearing loss has also been recommended by NICE guideline to get checked within 24 hours. These are immediate steps that should be taken, and to resolve these, usually CT head and MRI is being done. Now, causes of distress by tinnitus. Many times, as I have told you, we will be unable to find any cause of tinnitus for the patient. There are four theories currently that are being employed in this. There's habituation theory, neurophysiological model, cognitive model, and fear avoidance model. The neurophysiological model of tinnitus says that when a patient develops tinnitus, he gets aroused by it, which activates the limbic system, which in turn activates the autonomic nervous system. Once the autonomic nervous system is activated due to tinnitus, the patient feels palpitations, patient can feel tachycardia, sweating, which in turn will activate the tinnitus even more. And this will become a vicious cycle and cause distress to the patient. The second is cognitive model, in which the patient hears tinnitus and develops negative thoughts about it. These negative thoughts cause him to give selective intention and monitor the tinnitus even more and lead to even more negative thoughts. The third, the fear avoidance model. In the fear avoidance model, the patient develops a perception that if I do a specific task, the tinnitus will get worsened. He will start to avoid those specific tasks, which will increase his tinnitus, eventually causing him disability, generalized social anxiety, social withdrawal, and depressed mood. This is the fear avoidance model of tinnitus. Now, the management of the disease. You can say that disease in which we cannot find any cause, idiopathic, is a primary tinnitus, and it may or may not be associated with sensorineural hearing loss. The secondary tinnitus is any tinnitus in which we can find a disease underlying. So for its management, we simply need to treat the underlying cause. However, for the primary tinnitus, the management depends upon the extent to which the disease is bothersome. That is the quality of life of the patient, how much his sleep or concentration is being affected. First step in management is reassurance. Patient should be reassured that tinnitus is often idiopathic, self-limiting, and not usually indicative of any underlying health condition. There is no prescription drug for tinnitus, but antidepressant and anxiolytics can be given if the patient is in psychological distress. A new modality, digital tinnitus-related cognitive behavioral therapy, has shown good results in terms of quality of life improvements. As sensorineural hearing loss cannot be reversed, we should encourage patients to prevent it. We should encourage people to avoid listening to high volume music or high noise at workplace. This is a table that shows all the treatment modalities that we have in the management of tinnitus. The first line that the most effective is right now being dictated, it is the cognitive behavioral therapy. Then we can eliminate tinnitus by removing the tinnitus inducing medications. Then we can opt for hearing aids, sound generators, and other sound devices. We can recommend lifestyle modifications, give medications such as antidepressant, anxiolytic, educate the patient on the techniques, give stress reduction techniques, and advise therapeutic sounds. Now, these are the NICE guidelines of March 2020, and in which they recommend that among the investigations, audiometry is recommended by NICE. However, acoustic reflexes and autoacoustic emission is not recommended. And in the management, the counseling and reassurance is recommended. Sound amplification or use of tinnitus masker is recommended. However, sound therapy is not recommended. Combined behavioral therapy is again in recommended category, whereas the beta histine use is not recommended by the NICE. A simple case scenario we will discuss. Mr. A is a 67-year-old retired police officer who presents with concerns about ringing in his ear for the past 2 months. He described the sound as constant and high-pitched ringing that is non-pulsatile in nature. He has no associated ear pain and there is progressively decreased hearing in both ears. Additionally, his quality of life has also gotten worse. Can anyone tell me what else question? What is the next question that you should ask this patient? Yes, very good. We should ask the patient about vertigo. Other than that, hearing loss. Patient has hearing loss, progressively decreased hearing loss in both ears. Can anyone tell me what type of tinnitus is it? What type of hearing loss will this be? Sensorineural hearing loss. Why would it be sensorineural hearing loss? Because we can see that patient has the bilateral high-pitched non-pulsatile characteristic of tinnitus that Mr. A is experiencing is consistent with sensorineural hearing loss. Taking into account Mr. A's age, reported decrease in hearing, and previous occupation as a police officer, and a lot of noise exposure, most likely the diagnosis is presbycusis, acoustic trauma or noise exposure. Now, the otoscopic examination you have done reveals no signs of infection or middle ear masses. And I would now ask, what investigations would you offer Mr. A? Pure tone audiometry. What else if he wants further investigations? MRI. However, there is no indication of MRI in this patient. Finding of neurological in this patient, when we examined it, there was ear was normal, no neurological deficit. Audiogram showed symmetric high frequency sensorineural hearing loss with normal speech discrimination. And based on these findings, the Mr. A's tinnitus is most likely caused by a combination of presbycusis and noise exposure. So what should be the treatment? What will be? Quality is poor due to tinnitus. But tinnitus masker, you can offer him. What else should be the treatment? CBT. You can yourself reassure the patient that it is not a dangerous thing. So first is the conservative management strategy, in which you will ask the patient to perform dietary changes to avoid noisy environments, use white noise generators to improve the quality of life. You can refer him for cognitive behavioral therapy if the tinnitus continues to be bothersome. However, after 2 months, when Mr. A returned, he was aware of his tinnitus, but he was not bothersome about it. His regular activities were returned, his mood and sleep improved, and he was asked to continue with conservative management, so we did not need to go any further. The take-home message for tinnitus is that most of the time it can be managed conservatively. The red flags are pulsatile and unilateral tinnitus. As most of the tinnitus cannot be cured, we can advise health lifestyle changes to improve sleep, reduce stress, and reduce caffeine and alcohol. Some patient might from hearing aid or tinnitus maskers. And for those with persistent and bothersome tinnitus, cognitive behavioral therapy has shown to improve quality of life and decrease depression. Thank you. If you have any questions. Sir, I will start with the two main questions, hearing loss and vertigo. Yes, sir. Then I will go in detail about the tinnitus. First of all, whether it is pulsatile or non-pulsatile, then it is intermittent or continuous. Then when the onset, if it is सर हम अपनी जबान में कहते हैं कि मोटर चलती है जिस तरह वैसे महसूस होता है जिस तरह मोटर सिंक्रोनस अंदाज में चलती है यस सर दिल की धड़कन के साथ महसूस होता है आपको बार-बार लेकिन ये थोड़ा वीक नहीं हो जाता कोई फील करेगा दिल की धड़कन तो फिर ही बता सकता है जी सर इसी में फंसते हैं इसमें सर ये मोटर वाला एक बताया था ना यस सर intermittent continuous Yes, sir. बिल्कुल. Yes, sir. डिस्टर्ब इम्पैक्ट कितना है? स्लीप डिस्टर्बेंस है कि नहीं है? जी. सर मोटर चलती है, हम लोग तो पूछते महीनों से कि मोटर चलती है कान में, आपके जो आवाज आती है मुसलसल आती रहती है या बंद हो जाती है? Sir, they have divided tinnitus into various types. One classification is subjective and objective type of tinnitus, and roaring sound. Yes, sir. Yes. Clicking sound है. Other than that. कंटिन्यूअस जनरेटर है उसमें ऑलरेडी है वो. कोई पहले डायग्नोसिस नहीं, अपने डायग्नोसिस ऑफ एक्सक्लूजन को यूज करना है. स्पेशल हिस्ट्री हमें गाइड इस तरह करती है कि अगर पेशेंट में जो मेन क्लियर डिजीज है और आप ये इनको एक्सक्लूड करना चाहिए नेचुरल कैरेक्टर्स. सर पेशेंट बिलैटरल हीलिंग लॉस को पेन करेगा और पेन से ज्यादा हो जाएगा. सर पेशेंट की पेन करेगा. Yes, sir. बटाइगो के सर्कल में डिजीज.
तो अगर मैलियो डिजीज में क्या होगी होगा पेशेंट और नेक्स्ट कंप्लेन करेगा पेशेंट और उसमें भी पीके पे होना है और जब वो सेटल हो जाए तो डिफरेंट कैन क्लासिकल डिजीज का पीडीएफ ओल्ड एज पेशेंट आएगा हमारे पास लॉन्ग स्टैंडिंग हिस्ट्री होगी नॉइज एक्सपोजर की वर्क ऑक्यूपेशनल होगा ज्यादा तो आपने क्या टेस्ट किया so no two situations PTA is normal क्या करें so PTA is normal there is no issue ऐसा होना चाहिए अभी इंस्टीट्यूशन डिस्कशन हुई है मेडिसिन की भी आप एक्शन कर तो फिर अब क्या करेगा नॉर्मल है सर पीटीएस नॉर्मल है तो हमारा जो एग्जामिनेशन भी अगर नॉर्मल है इसके अलावा इसलिए फिर सर इसको प्राइमरी टिनिटस या इडियोपैथिक टिनिटस की कैटेगरी में डाल देते हैं और इंस्टेड ऑफ इसके डायग्नोसिस के लिए ट्राई करते हैं कि पेशेंट की मैनेजमेंट की देखते हैं कितना बहुत समझ पहले इससे पहले की टैक्सी बस काउंसलिंग है एबिलिटी के पेशेंट है अगर पेशेंट को डेली रूटीन में स्लीप इश्यूज है या और डिस्टर्बेंस है और अवॉइडेंस ऑफ प्रेसिपिटेटिंग एक्सरसाइज मल्टीपल स्क्लेरोसिस में tinnitus होता है। Yes, sir, बिल्कुल। तो particularly बहुत है। ये टेस्ट के आपको 5 फॉर्म मिलता है। रेस्पिरेटरी करो या रेस्पिरेटरी करो कुछ में इनको मिलता है। टिपिकल पैटर्न को बस इस सब क्या है ट्राई टू फाइंड द लिपिड प्रोफाइल iron टेस्ट जैसे LFTs डिस्पैरिटी है थोड़ी अमेरिकन और ब्रिटिश में। ब्रिटिश लिटरेचर है जो उनके जर्नल्स हैं वो ये जो आप सब है वो मॉडरेट जैसे थायराइड डिजीज है वो इसको स्ट्रॉन्ग फैक्टर समझते हैं business के लिए। लेकिन जो अमेरिकन रिसर्च है जो लेटेस्ट है वो इनको रेलेवेंट नहीं समझते, स्पेशली थायराइड डिजीज को वो कहते हैं कि tinnitus के साथ इसका कोई लिंक नहीं। करते क्या है बहुत से ज्यादा कोई ट्रीटमेंट और ये है कि कितने कुछ की पेरेंट्स में देखे हैं काफी ज्यादा। तो मैं आपको ये सब को मॉडरेट से कोड लेके दिखाऊं सर नाइस गाइडलाइन है और बीटा स्क्रीन नहीं देंगे तो कोई रोल नहीं है क्रेडिट नहीं है। लेकिन हमने प्रैक्टिस में देखा है पेशेंट्स पेशेंट कहते हैं कि दिल पा जाए दूसरी तरफ कुछ ऐसे भी है कि चीज को फाइल होगा अपने को करेंगे कभी कभी वो है मेरे किसी दिन को फायदा नहीं होगा ये फैंसी ड्रग है न्यूरोटॉनिक दवाई तो एनी न्यूरोटॉनिक एक सप्ताह करके आता था क्या कुछ चांस तो बात कर रहे हैं इंटरेस्टिंग तो there is no harm normal in spite of that level. ठीक है to be clear test history is noise pictorial. ये बॉल लगाइए तो कितना होगा less than 90 minutes or 90
ऑनलाइन शाहिद मलिक साहब का सवाल है, व्हाट आर द सर्जिकल ऑप्शंस फॉर मैनेजमेंट प्लीज? डॉक्टर अली से एक क्वेश्चन है मेरा कि मतलब इन टर्म्स ऑफ रिसर्च इंटरनेशनली जो डिवाइसेस डेवलप हुई हैं उसके बारे में थोड़ा हमें बता सकते हैं, और व्हाट आर द एफडीए अप्रूव्ड ऑप्शंस, आर देयर एनी एट द मोमेंट फॉर दिस डिजीज?
Various types of devices have been created for this disease, but the only FDA approved yet is the tinnitus masker. Tinnitus maskers are recommended in the Navy guidelines as well. Other than that, there are some sound therapy in which they give patients sound with various types of sounds for 1 to 2 hours daily, and they say that patient has benefit in it. Other than that, there is transcranial stimulation of vagal stimulation of auditory cortex. And there are various other advanced experimental studies that are being carried out right now, but none of them have any recommendation for patient use or in clinical practice yet.
Like some physiotherapy, some sound therapy, there are so many tinnitus, and that is very different join, and different patient has get from different therapies, so they share. Getting your knowledge, you can join that. So every person is sharing his own experience for the treatment. Invest में काफी ज्यादा, लेकिन हमारे मोस्टली जो पेशेंट है वो कंप्लेन आके करते हैं कि आवश्यक ऐसे और रह रहे होते हैं टाइम वेस्ट में बेसिकली वो नॉइस पोल्यूशन कम है वो और बाई सेकेंडरी साइकोजेनिक और में काफी ज्यादा काफी ज्यादा यहाँ भी what else? Obviously, there is a medical pathology. The visual, so the visual promise.
Tinnitus, oral fullness, hearing loss.
Second, classically, जैसे चलता है सांस basically are checkers. Investigate. And obviously check for the classical globus. Tinnitus brain is obviously a very good. AE tests फाइनल क्या होगा लाइसेंस को है या लास्ट एक्सपीरियंस बिकॉज़ लास्ट टाइम जो एक अब्दुल आई तो कह रही है मेरे शादी में गई मैं स्पीकर के पास बैठी बेसिकली ये ठीक है बाबू क्योंकि वो ऐसे कैमरे बस्ट हो गई टिपिकल मेरी लॉस हुई मैं पूरे हिस्ट्री में पूछना चाहती थी एक्चुअली जो ह्यूमन जो रेंज है ना वो 1 to 5 से 8,000 से ज्यादा साउंड जैसे प्राइस प्राइस वाला जैसे कोई इंडस्ट्री में काम करता है या किसी मशीन में ये प्रोडक्शन होती होगी प्राइस में इसी साइड ये जब कोई रिलीज तब कहा ये है विश्व नो डेवलपमेंट नाम से ज्यादा डेवलप हो गया इस इंजीनियरिंग को पूरी कैलकुलेट नहीं करता मैं तो कहते हैं एक मैंने एक विश्व इंडिया के पास है 500 सारे लोगों को ऐसा कहते हैं नहीं कॉम्प्रोमाइज हो गई मेरी आंसर यस इज ऑप्शन ये बेनिफिशियरी ऑफ the steroids or steroids. इसकी फुटप्रिंट जब यूज करती है तो रियल में पैसे को कंपनसेट करते हैं ये टैक्स का हमारा है पहले कंप्यूटेशन समटाइम्स साइड ऑफ कंप्यूटेशन ऐसी भी तो सेट प्रॉपर्टी को साथ इतना है लॉस कंप्यूटेशन ज्यादा सिस्टमैटिक
क्या समझ रहे
So, see the cause is what you ENTs that try to find out. Yes, MRI is indicated. So, certificate hearing loss needs some right. You need to yes. So, it's a medical question. Then legacy when can the legacy more legacy not given to also
पेशेंट की नेगेटिव काउंसलिंग कर देनी चाहिए पहले विजिट में या नहीं?
this is negative counseling because this is reassurance. उससे reassure कर रहे हैं but the quality of life is discussed but no harm. ये इसको नेगेटिव काउंसलिंग नहीं करते नेगेटिव काउंसलिंग reassurance करते हैं काउंसलिंग का नाम देना आप नेगेटिव जो भी काउंसलिंग है उसमें नेगेटिव भी बताना होता है काउंसलिंग जैसे हम बहुत लाइक्स हम कर रहे हैं काउंसलिंग में हम ओल्ड एज पेशेंट को आप क्या काउंसलिंग करते हैं काउंसलिंग करते हैं कि आपको केमिस्ट भी हुआ हुआ है आप ब्लड प्रेशर पे भी है इंजेक्शन प्रेशर भी कम है ठीक है तो आप बेड पे जा सकते हैं हाई रिस्क है लेकिन प्रॉब्लम ये है कि हम आपको सर्जरी ट्रीट नहीं करेंगे ये बीमारी खत्म नहीं हो सकती ऐसे इसको सारा कुछ बताने के बाद आप अच्छी चीज में बताते हैं once tumor is out then life will begin पहले वर्सेस दोनों चीजें हैं या जो प्रोसीजर आप कर रहे हैं उसके कितना है सो कॉम्पिटेंसी भी बताइए यू आर इन सेफ हैंड्स नो वरी हमारा सक्सेस रेट ठीक है उस पे ट्रस्ट कर सकते हैं, आई कैन हैंडल द सिचुएशन। कम्युनिकेशन में स्टक हो जाएगा, नो वरीज, आई कैन हैंडल दैट। ठीक है, अपने आप को स्कोर आप अपने आप के देख लो, आप ऐसे के पास जाएंगे भी शुरू है मेरे बारे में
Yes,
इसके बारे में सर बता दें कि हमारे पास फैसिलिटी है, ठीक है, कि हम उसके लिए अगर भेजें और आगे भी इतनी कॉन्फिडेंस है कि उसके लिए उसके लिए कर सकते हैं। हम एक प्लेयर का ऐसा सेगमेंट है जो अटेंड हुआ, हमारे पास बहुत ज़्यादा टेस्ट अवेलेबल नहीं है एक्चुअल से इससे टेस्टिंग हर काम में निकले और अपनी हर कम्युनिकेशन सारी कुछ इसमें ये है, इलेक्ट्रोमोग्राफी है, पोस्टोग्राफी है, आप लोग दस है ये जो डायबिटीज के मास्टर में लगता है कि इससे लिए नहीं हुआ है डिवाइस की बेस पे कैलिब्रेशन का ये जो डायबिटीज का बेसिक है उसमें ये जरूरी है जो मास्टर है ये तो प्रॉब्लम दे सकता है। अब मैं आप बताइए ये ये मास्टर है ये डिफरेंट साउंड्स है, साउंड्स साउंड्स का पहले साफ कर लिया एक्चुअली कर लिया यानी टेस्ट के लिए ड्यूरिंग ऑडियोलॉजिकल टेस्ट हम मास्क करते हैं वो काम को मास्क करते हैं इस काम में फेस करते हैं जो न्यू डिवाइस है वो लीनियर डिवाइस जो एफडीए अप्रूव हो चुकी है उसके 3 फेज ट्रायल्स कंप्लीट है वो सर टंग के साथ उसका कोई उन्होंने लिंक किया है वो मैं डिटेल से अभी पढ़ा नहीं था वो एक मैगजीन में था कि टंग की सेंसेशंस के साथ कोई नर्व इम्पल्सेस जनरेट होंगी और tinnitus का 80% उसका सक्सेस रेट है उस डिवाइस में। हाँ लीनियर LENIR ट्रीटमेंट है लीनियर ऐसी सिचुएशन भी शो रिसीव करते हैं, एक्चुअल पेशेंट को ऑटो फोन नहीं हो रही है, क्लिकिंग साउंड हो रही है, ऑटो फोन नहीं
वर्सटाइल वर्सेस नॉन वर्सटाइल जो है, आप सर को बता दें कि वो किस तरह कनेक्ट बहुत मुश्किल चीज हो जाती है, हर मरीज नहीं समझ पाता अगर फर्स्ट के लिहाज से पूछना।
क्या कि इस शोर की आवाज आपके दिल की धड़कन के साथ निकल रहा है, जब दिल की धड़कन तेज होती है, जैसे कि आप तेज चलते हैं, सीधे चढ़ते हैं, जब कान में आवाज तेज हो जाती है, ये सबसे आसान तरीका है। यस, एक्चुअली कॉज जब भी कॉज के सेगमेंट में आएगा, फिर आप ही उसको बताइए, आप किसी के पास भेजेंगे तो कैपिटल इनफ, आपने पेशेंट की साइको समझ गया है, जैसे कि डोमेन है साइकियाट्रिस्ट, actually there is a lack of coordination between the treating physicians. डर होता है कि हम अपनी मरीज को किसी को आप दे दें, वो अपना ही काम शुरू कर लेगा, ऐसे वो अपने जस्ट अपनी चीजें आप ही बात नहीं सुन रहा हो। मेरे पास एक पेशेंट आ गया, उसको क्लासिकल स्पीनियस सर्विस क्लासिकल नहीं, तो मैंने कैसे किया कि आप सीधा टीम को इधर फ्रंट ऑफ इधर आ रहा हूँ, क्लासिकल मरीज मैंने देख ली रेडियोलॉजिस्ट सीरियस सेमिस्टर डिसीज है, थर्ड प्रॉब्लम जो विंडो बनाना है इसको, और इसमें ये है मुझे I'm interested only in the semi-survey especially to see any defect in the superior semester. मैंने भी आधे पेज की उसे रिक्वेस्ट लिखी भेजी, लेकिन अभी भी मोबाइल में है उसकी, मतलब उसने मेरी किसी बात पे तो मेरी लिखा तो रेस्टोरेंट स्माइल है, प्लान है, प्लान है, प्लान है, तो फिर मैंने उससे रिक्वेस्ट ली, आगे आपके लिए कर रहे हो हमारे ये इससे सब है तो कोऑर्डिनेशन सब है तो कोऑर्डिनेशन परीक्षा है जाएगी आपके कोऑर्डिनेशन में बात बचा रहे और जो बात कुछ नहीं अभी तक तो डेटा जो भी लगे हैं कोऑर्डिनेशन